Our next speaker, Dr. Logan Kosarek, an adult cardiac anesthesiologist locally.
Thank you. All right, yeah, thank you for the invitation to speak. Honored to be among so many perfusionists. Wait for my presentation to come up here, but
on the screen.
It's frozen.
Well, you can see it on the cursors over there, but it doesn't come up to the laptop. Maybe we'll get there.
See if you can scroll it. Get this cursor and scroll it onto this one.
Yeah,
Did it come all the way down to the left?
there you go.
yeah, that's me. Perfect. Thank you.
All right.
Appreciate that. All right, well, yeah, I'm a cardiac anesthesiologist at Oshner just down the road, and I mean, the best part of doing cardiac anesthesia is getting to work with perfusionists. The coolest, at least at Oshner, they're the coolest people in the hospital. Dean, act like you've been there, man, come on. Second best part is doing echo. Love doing echo, making great pictures and getting good information, and doing echo is just a lot of fun, I think. As you might imagine, they have multi-day conferences committed just to echo. So what I'm going to go over is a bit of a whirlwind of bullet points and highlights that may occasionally tangentially be of interest or relevance to you. So chambers and valves, structure and function, that's kind of the bread and butter. I'll go over a few unique pathologies, show you a lot of clot and emboli, some pictures of some devices, cannulas and other prosthetics, in particular prosthetic aortic valve, and then a little bit of quantitative echo. So as I said, assessing the structure and function of the ventricles and the valves is kind of that's the meat and potatoes of doing echo, really. What you see here is close enough to normal 4-chamber, mid-esophageal 4-chamber view of the heart. So the thing at the top there is the left atrium. That's the thing that's closest to the probe almost always. And the valve closest there is the mitral, and then obviously followed by the left ventricle. And you also see the right atrium, tricuspid valve, and RV pretty well. You can see it squeezing pretty good, and you can start to approximate an ejection fraction and the size of the ventricles themselves relative to one another, and that the mitral and tricuspid are coapting pretty well. The aortic valve obviously isn't seen here. That'd be the other valve of interest. The pulmonic valve, nobody really cares about, sorry to say. The Ringo star valve, as we call it. All right, so this, the normal's on the left, and next to that would be somebody who's here for an LVAD. And you can start to appreciate that the left ventricle's dilated, and the RV's dilated as well, to be frank, and the LV also. The walls are thinned out, but most importantly, it's just not squeezing well, not at all. The EF on that one is probably 10, something like that, whereas the normal one's more like 55. So that's when you can start to see some of the structure and function get out of hand. These are two different ventricles, both of which are severely abnormal for very different reasons. The one on the left is very thick, so the ejection fraction is normal. You might even call it hyperdynamic. I mean, the ejection probably is 90%. It's all the blood is leaving as the endosystole is completely, the intracavitary is completely obliterated. But it's very thick, so even though the systolic function you could classify as normal, the ventricle itself is very abnormal, and of relevance to you, this would be a ventricle that's very hard to protect. A lot of muscle there to get the cardioplegia to. And the ventricle on the right is very similar to the one we just saw as someone who needs an LVAD. So these are both, by the way, transgastric LV short axis views. You can see in both images the two little nubbins within the cavity of the ventricle are the papillary muscles. And we're just kind of slicing the LV and short axis right across the middle of it. But again, that LV on the right is very dilated, the wall is thinned out, and just not squeezing well at all. These are a couple more transgastric LV short axis views. These are of interest because they showcase regional wall motion abnormalities. So parts of the ventricle are squeezing well, and parts either aren't squeezing at all, or squeezing very little, or sometimes squeezing the wrong way. Well, not squeezing at all, but being punched out the wrong way, and that would be a dyskinesis in that instance. These are most commonly developed when somebody has severe coronary disease, and you can start to pick out which coronary is affected based on which part of the wall isn't moving. And so that's another big way in which we use echo in the OR, and really pre-op as well, to start to potentially even pick out which coronaries are involved with the disease. Here's another abnormal heart. In this case, it's the right ventricle that's severely dilated and dysfunctional. So again, the normal is on the left, and on the right is a patient with severe RV dysfunction from primary pulmonary hypertension. They were actually there to get a lung transplant for that. Somewhat similarly, this is another patient who has severe RV dilation and dysfunction. But rather than primary pulmonary hypertension, they have a significant valvular abnormality causing this problem, and that is severe mitral regurgitation. So you can sort of pick out on the loop on the right side there, one of the mitral valve leaflets isn't coapting at all with the other one. So the posterior leaflet is completely flail. By flail, I mean the cord that should attach to the papillary muscle is freely mobile within the left atrium during systole. So another picture of that is here. So this is the mitral valve in 3D, and that's integrating 3D into echo has been a big boon for doing TE in the OR, especially when we're talking about imaging the mitral valve, because you can, the mitral valve is so close to the probe that it images really well, and that's particularly true in 3D. So in this 3D picture, the portion of the mitral valve that's in the top of the screen is the anterior leaflet, and the portion at the bottom is the posterior leaflet. It's called the surgeon's view because this is how they would see it in the OR. And you can kind of pick out that the middle portion of that posterior leaflet, it's kind of a knuckle bowing up towards us during systole towards the screen, with the pap muscle flailing in there. It's like, I think this image is like it's giving us the finger, and that feels about right because it's saying I'm done working. This is the same mitral valve next to a totally separate one that rather than having flail of the posterior leaflet, you can sort of appreciate it has flail of the anterior leaflet, which is a less common problem. Somewhat thankfully, the posterior leaflet's a little bit easier to repair. But again, these are both pretty clearly show you what the problem is with the mitral valve, and 3D kind of gives us that advantage, especially with this valve. This is a very unfortunate heart, not really working well at all. So the right ventricle in particular is even worse off than the left, even though the left isn't doing so hot either. So the right ventricle is very dilated, and I included this one because it's basically the worst right ventricle I've ever seen. Another thing we can pick out on this image is in the left ventricle you see this sort of stagnant, smoky looking blood, and we tend to call it smoke, but the proper term for it is spontaneous echo contrast, and that's what slow moving blood looks like on echo. And to have slow moving blood in the left ventricle is a major problem. Obviously that's where the blood should be moving quite fast, and the blood is moving so slow in the right ventricle that it's actually formed a bunch of clots. So all that gray smudge at the bottom of the apex of the right ventricle, that's all thrombus. This patient actually, they had a PA catheter in. They were coming into the OR for ECMO. I don't know if I mentioned that, but they have a PA catheter in, and their right atrial pressure measured on the PA catheter was the exact same as their PA pressure. So they basically had Fontan physiology, really, for as bad as this was. All right, that's all I really had on the structure and function of the ventricles. I'm not really going to dive too deep into the structure and function of all the valves. That would be pretty comprehensive. But this is a patient who, at least to show you this one view, this is a mid-esophageal aortic valve in long axis. So you can see the mitral closer to the top of the screen and the aortic valve next to it. And both of these valves have significant regurgitation, MR and AI. Again, this would be a perfect view, be able to look for the AI. If somebody had significant AI, you'd almost always be able to pick it up right here. And I include this only because it's something the surgeons almost always ask us about that is also of relevance to you, in that this is a patient who would not get very good arrest if we did 100% antegrade cardioplegia. All right, just to run through some unique pathologies that image particularly well with echo. A lot of these first ones are different clots, but this one is a saddle PE. So the image on the right would be a normal mid-esophageal aortic valve, aorta in short axis. So the big black circle in the middle of the screen is the aorta, and the sort of tube running up sideways next to it on the right side, that's the PA, the main PA going into the right PA. And again, the video on the right would be normal. Whereas on the left, you can sort of pick out there's something flopping around in the main and right PA, and that's about as big a PE as you could ever have, because it's what we call a saddle embolus, where it sits right in the main PA as it bifurcates into right and left, and so the PA acts as a saddle for the PE to cowboy into. This is another patient with a PE. This PE is sort of incomplete, if you will. It's kind of bouncing around in the right side of the heart. They had distal clot burden in addition to this ping pong ball of clot, and we sized it out. It was the size of a ping pong ball bounced around the heart. This is one of the more unique echoes we came across, just because, as you can see, it's freely mobile, wasn't attached to anything, and we were just all kind of clenched up, ready for it to make its way into the PA and cause right heart failure. Both of these patients, the saddle PE and this one, they were obviously there for embolectomies. This is another clot. So this is a 3D picture. I'll try to describe there. On the right side in the background is the mitral valve, and on the left side in the background is the tricuspid valve. And so the 3D bit of tissue bridge running up and down the screen, that's the interatrial septum. And that snake-looking worm thing is a bit of thrombus that is on its way to be a PE, and then it got caught up in a PFO. So that's could have been a very devastating thing if it made its way. Obviously, a PE is bad enough, but then if you start getting clot on the left side, obviously that has its own problems. So those are some thrombi and emboli. This is another thing that I think is kind of cool that's relevant to perfusion and surgery as we go for cardiac surgery is with intra-op TE, you're able to diagnose a persistent left SVC, which is granted a relatively uncommon problem to have, but it can be a problem that the patient makes it all the way to the OR without it being ever diagnosed. One of the clues we could start to figure out that it might be what's going on is when the coronary sinus is very dilated. So the coronary sinus should only be about a centimeter, maybe a little bigger. So once it gets up to over 1.5 or 2, like this one's about 2 centimeters big, that's the kind of black stripe towards the top of the screen with the bubbles and air in it kind of dumping into the right atrium. That's the coronary sinus. And it becomes enlarged because the persistent left kind of drains into that coronary sinus, making it dilated. So the way we're able to diagnose is if the patient has an IV on the left side, you just inject air through the left-sided IV, and the air, instead of first appearing in the traditional SVC spot, will appear in the coronary sinus first. And so that's how we're able to diagnose it. And obviously that has major repercussions for doing retrograde cardioplegia and cannulation and such. All right, those are the unique pathologies I kind of chose to go over. I guess I could have included things like some aortic dissections where picking out a flap and picking out true versus false lumen. but I kind of contained it to those. But anyway, I'm going to run through some different devices and cannulas and how they image on echo. This is something we do every day all the time, is to verify optimal placement of a venous cannula. This is just a single 3-stage cannula that's going in from the right atrium into the IVC. So what we're looking at on the screen, that organ kind of encompassing most of the screen is the liver, and the big black stripe at the top is the IVC. This becomes important not only for making sure the venous cannula is at a good and appropriate depth, but to also make sure, in my mind, the most important thing is that it doesn't go down the hepatic vein, which is that big black stripe kind of running up and down on the screen. You can see how that venous cannula might be able to find its way in there and impede our adequate drainage. This is what a LV vent looks like on echo. It just has a very distinct look to it. Not that the surgeon would ever really have, they've never really had trouble putting an LV vent in, but this one, because it's so distinct, this image of one very much like it was on my echo board, so always think about that. This is what an impella looks like on echo. This is a mid-esophageal long axis view. So the top, you have the left atrium, then the mitral and the LV below that, and then the impella kind of making its way from the LV out into the aorta. This is an impella that I would say is very well placed in terms of, for one thing, you don't want the curve to be going up towards the mitral valve. So sometimes that'll happen, and then the surgeon or cardiologist will just kind of spin it until it's pointing more towards the mid cavity or towards the apex. And the other thing is you want to make sure the inlet is not too far or too close from the mitral valve, from the aortic valve. So we might have them advance or withdraw a little bit, and that's usually the most common thing that we'll do to assist them in placing it so that it's positioned well. And thankfully the impella, like most prosthetic things, it just images really well and brightly on echo, and you can see that in kind of the mid LV cavity, there's kind of a teardrop looking artifact, that white kind of blended stripe at the very tip of the impella. It makes it real easy to help place where the inlet is. I like this echo in particular because this same patient, after they got the impella later that evening, they came back for a heart transplant, and by that time the impella had migrated out a little bit, and so this is an example of a well-placed impella and one that probably needs to be advanced a little bit more ventricular, because as you can see, it's starting to, the inlet is really close to the aortic valve, and you probably wouldn't get as good a flow or some like mixing with it. All right, here's another nice bread and butter thing that is great for echo and establishing images that are important for everyone to see and help manage the patient. This is a patient with a fresh LVAD, and so you can see that the inflow cannula is sticking out and the apex there, and you can kind of appreciate that it's the inflow cannula is pointing right at the mitral valve, which is exactly how you want it. So this is a well-placed LVAD with good inflow alignment, and that, especially on the right-sided video, you can see that you can really tease out that inflow cannula nicely. It looks like a little tube, little tunnel pointing out towards the mitral valve. This is another thing we can use 3D for. This is maybe a little excessive, but it is fun and it images really well. And it's kind of nice to be able to, especially that video on the right side of the screen, you can flip the image around so that you're looking at the mitral valve, and you can crop the image through the mitral valve into the left ventricle, so that as you go through the mitral valve, you see that hole, that inflow cannula staring right at you. The cardiac surgeon who does most of our LVADs is he's a colorful guy, and he calls that the bird's ass view. So I always thought that was funny. I don't know how he knows what a bird's ass looks like. So those would be a well-placed inflow cannula. This would be, in opposition to that, a poorly aligned inflow cannula, and you can appreciate how the inflow is pointing almost side to side rather than up and down. It's pointing right at that kind of anterior septal wall of the left ventricle. So if an LVAD should be placed like this, it's kind of pointing like that. And this patient was actually coming into the OR for a heart transplant, thankfully, and as you might imagine, they had significant low flow alarms constantly on their LVAD, and so if we put color on that malplaced or malaligned inflow cannula, you can see that acceleration of flow, that sort of change in color, right? It almost creates a little pinch point right where the inflow cannula is. In addition to the inflow cannula, we can look at the outflow graft as well. The image on the left is the big black stripe going across the screen is the aorta. And the color, the splash of color dumping into the aorta is from the outflow graft. So it'd be important to measure velocities at both the inflow cannula and the outflow graft to make sure that they're low, appropriately so. I also like this image because when we put a Doppler, spectral Doppler on that outflow graft, that's the image on the right, the Doppler imaging. You can see it's pulsatile, so someone can be pulsatile with an LVAD, obviously, and that doesn't, that includes folks whose aortic valve isn't opening. So just because someone's pulsatile with an LVAD doesn't necessarily mean that the aortic valve is opening. It could be the pulse is being generated through the VAD itself. We've seen that plenty. So I thought that was kind of a neat side bit, because you kind of hear folks, and sometimes we assume it too, that if somebody's got a pulse, it means the aortic valve's opening a little bit, but that's not always the case. This would be what an LVAD suck down looks like. So we see a fair amount of that with folks with VADs. Probably the most common reason we come across, at least in the OR, for the low flow alarm to be going off. Which, by the way, that's the low flow alarm is the top 10 alarm in terms of annoyance. Kudos to them. It's one you really can't ignore, and probably shouldn't. So here we can see the right ventricle is dilated. That's the ventricle on the left side of the screen. And the LV, frankly, is very hard to see here because it's collapsed. The LVAD has sucked all the blood out of it almost. And so this would be a good example of that, of a suck down event. And which again is something you can easily see with echo, and it's very useful in folks who have an LVAD. All right, so that's what I got on LVADs. This is really the only prosthetic valve I'm going to show you because it's the most interesting one I got. So this patient was coming in for a double valve, actually. The mitral and aortic needed to be replaced. And we decided, as we often do nowadays, to put in this Percival valve, which many of you probably are familiar with. It's basically like putting in a TAVR valve surgically. So it's a sutureless valve that exists in a kind of stent, which you can see some examples there. And even though there are some guiding sutures placed initially by the surgeon, when it's all said and done, it's not sutured in at all. And the advantage there is it doesn't have a sewing ring, so it makes for a nice wide effective orifice area. And so there are excellent gradients through that aortic valve typically. And also a great thing about the Percival valve, at least I think so, is that you size it like you'd size a t-shirt, which I think is pretty funny. So this patient is getting a Percival valve in addition to their mitral valve, and this is when we are initially starting to come off pump. Really the clamp is off. We haven't started to fill the heart at all yet. And you can already see one thing we always make sure of when a new valve is put in is to make sure the annulus is stable. So a stable annulus, that the leaflets are all moving, that there's not any paravalvular leak. Those are all critical to assess any new valve. And you can already appreciate here, this would be a long axis view of that valve, so you can kind of see the stent going side to side across the screen, the kind of bright white lines that are moving a little bit. And you can see within that stent are the leaflets of the new aortic valve. And that stent is already starting to shuffle around a little bit, and we haven't even started to fill the heart yet. And we kind of mentioned that to the surgeon, but he was like, okay, well, let's just give it a shot. And we gave it a shot, and it just popped loose. Completely loose. Yeah, pretty gnarly. Just freely mobile within the aorta. Thankfully, the distal portion of the ascending or the mid ascending was a little bit smaller than the proximal portion, so it kind of got caught up before being ejected way distal into the aorta, which we've seen with TAVRs before. I'm sure especially if you were around when they were first starting, they got into all kind of shenanigans, and sometimes the TAVR valve would go way down into the descending and it would just stop there. And thankfully, if it's going in the right direction, you just got a new valve in your aorta. But anyway, this had to go, so we went back on pump and they just replaced that Percival valve with a more traditional tissue valve. We've had a lot of success with the Percival valve. I actually really like them. They image well, and they do provide those good gradients, provided you can get them seated. All right, this is the last bit of the lecture. So just a bit about quantitative echo. I thought these are some interesting things you can do with echo outside of just making good pictures. So the video there we see is what we call a deep transgastric view. And what's important about this view is at the bottom of it, you can see the aortic valve moving a little bit, kind of opening during systole. And the reason this view is important for our purposes is because the blood is moving parallel to the ultrasound beam. So the ultrasound beam is coming out from the top of the screen and going through the aorta. And so we can get spectral Doppler through there. So you need for the blood to be moving parallel or very close to the beam of the ultrasound, otherwise Doppler is useless. And so if we put our Doppler beam through that aortic valve, we get this image, and those little blips going under the baseline there represent flow out of the aortic valve in the LVOT. So if we measure that flow in the LVOT, if we trace it, the area under the curve is something called a velocity time integral, or a VTI. It's really not important what it's called, other than that we think of it as a stroke distance. So it's a distance that a volume of blood travels. And in this case, it's about 20 centimeters, so a distance measured in centimeters. And if we then go back into the mid-esophagus and measure the LVOT diameter, and if we assume the LVOT is a circle, which it isn't really, but we assume it is just to make the math easier, we can get the area of that circle, which is pi r squared. And so if you have that area times the stroke distance, it gives you a centimeters cubed, which is of course a volume, and that's your stroke volume. And as long as you know the heart rate, you can calculate a cardiac output. So it's not the easiest way. It's certainly by no means the gold standard for measuring a cardiac output. That'd be a PA catheter. But when you have a PA catheter in place and you compare these measurements to that, it turns out to be pretty accurate. So that's a pretty cool thing you can do with echo. Another pretty cool thing we do all the time, and maybe of all the quantitative echo available, this is probably the most popular one, is to use the Bernoulli equation. Well, first I'll mention that video there, the color box is over the tricuspid valve. So the thing at the top of the screen is the left atrium. Then you see the interatrial septum, the right atrium, the tricuspid valve, and the right ventricle below that, squeezing away at the very bottom of that video. And so the color there during systole represents tricuspid regurgitation. So if we put and you can see the TR is going pretty well parallel to our ultrasound beam. So if we put our Doppler across that TR, it'll give us this big wave going above the baseline at the very right of the screen. And if we measure the top of that wave, it'll give us a velocity. That's all still Doppler principles, to be able to get velocity of blood as it travels parallel to the ultrasound beam. But where Bernoulli came into relevance to us is he came out with this very complicated equation as relates fluid to gradients and velocity. We simplified that equation way down to just 4v squared. So if you plug the velocity into that v and it's 4v squared, that'll give you the pressure gradient. And so in this case, we get a pressure gradient of 31. And that pressure gradient represents, in this case, the gradient between the right atrium and the right ventricle, because that's where the TR is going between. And so if we add the right atrial pressure to that gradient, which is the CVP, you get the RV systolic pressure. And it turns out this, in opposition to the cardiac output, which I just mentioned, this is highly accurate and very easy to do. It takes but one equation and calculation to be able to very accurately estimate PA pressures, which is obviously very useful. And one of the reasons why echo, this is one of the small reasons, but it's one of them why echo is kind of starting to edge out PA catheters as the monitor of choice for cardiac surgery. And if you ever see a pre-op echo and it's reporting what the PA estimated PA pressures are, this is exactly how they do it. Every echo would do it the same way. And that's, again, a highly accurate way of doing it. The last thing I'll mention, even though this is something we almost never do, but I did think it was cool enough to mention, is you could use Ohm's law, which is voltage equaling current times resistance. And if you just rearrange that equation to solve for resistance, it turns out there are voltage and current equivalents in echo. So that TR Vmax, that's actually somewhat equivalent to a voltage, and the RVOT VTI or the LVOT VTI, either one of those, that stroke distance we talked about earlier, that's equivalent to a current. And so that you can solve for PVR, which again is not, probably not the most reliable way of doing that, but it is something cool that echo can do. All right, thank you.
Thank you so much. And we're going to have questions at the end, just for the sake of time, stay on schedule. Our next presenter is Desiree Bonadonna. She is the Chief of Perfusion and the Director of ECLS for Duke Health. She's going to talk to us a little bit about onboarding process.
All right, thank you. I'm going to talk a little bit about how we do onboarding for new perfusionists at Duke. I have no relevant disclosures, and I do want to share my greatest appreciation to those who have helped develop this process over the years: Sandra Harris-Holloway, Willie Dausch, and Carmit Levy. I also want to acknowledge the tremendous efforts of the entire Duke Perfusion team in welcoming our new employees and adequately preparing them. I'm going to focus this talk on the 2-year process and investment of onboarding a new graduate perfusionist at Duke. Onboarding really begins at the time of offer acceptance. It often takes a minimum of 8 weeks to clear the State Bureau of Investigation in the state licensing process. A North Carolina provisional license is required prior to employment commencing, and there's the standard pre-employment screening as well. 1 week prior to the scheduled start date, all documentation is verified, and we start initiating the process for obtaining IDs, IT access, and parking. We still have to pay for parking. Day 1 at Duke is the branded hospital orientation, where general hospital policies are introduced, compliance requirements are explained, and the process for benefit selection begins for our employees. They are offered many resources to help in these areas from the hospital. The remainder of the first week focuses on introducing the new perfusionists to our department, including our policies and procedures, our various learning modules, in-services for our particular bypass pumps, cell savers, heater coolers, point-of-care devices, and our EMR. Just the basics to get going on a bypass case in our OR. We also review infection prevention procedures, and we have our new perfusionists begin setting up pumps, working with our simulator, and observing cases. The second week then focuses on gaining comfort with our OR procedures, developing relationships in the OR with our anesthesia and surgical colleagues and our nursing colleagues, and getting used to our morning routine. If ready, the new perfusionist will begin pumping cases with one-to-one preceptor support. Weeks 3 to 6 focus on our new hire gaining reps and fulfilling their case requirement to sit for boards. We attempt to get the perfusionist a wide range of cases in that time period. Weeks 7 and 8 are then focused on ECMO, our convertible ECMO to bypass circuit, VADS, HIPEC, angiovac, apheresis, and all of our other ancillary devices and techniques. This time allows for a wrap-up of any remaining competencies and time to shadow in our ECMO units. The next 8 weeks, our new perfusionists will be placed on the call schedule as an additional member of the call team. They'll be provided additional support and supervision, but will function as a staff perfusionist. Around week 18 of the orientation process is typically reserved for studying for and taking the board exams. It usually takes about 4 to 6 weeks for all documentation to come through from both the ABCP and the state for full licensing as a licensed perfusionist. At this point, the perfusionist is an independent CCP LP, and they function as such within our hospital. As the perfusionist approaches their 1-year anniversary, they'll engage upon clinical instructor and super user training. At the 2-year anniversary, the perfusionist will train to become a charge perfusionist. Duke's culture commitments include putting people first, being clear and empowering, and adapting to improve. So to make sure we're very clear on expectations, our orientees are provided a very detailed schedule with links to all necessary resources and documentation from day 1. We also outline our expectations to our preceptors to create a positive learning environment for our new hires. Besides basic professionalism, we request the preceptor provide detailed support and oversight of all of their activities. We outline for our new hires their work expectations, including reporting time and how they will operate. We also refer our new hires to the AMSECT Code of Ethics and professional and behavioral expectations. We attempt to set up our new hires for success by making suggestions that will help them acclimate into our work culture. We clearly outline all occupational and environmental safety requirements and give them the links and titles of everything they need to do, as well as the many, many, many required learning management system modules. There are a few perfusion-specific modules and resources, including our amazing video competency library that we make available to our new hires, and we make sure that they have everything right from the beginning so they know where to go for references and resources. As the new hires begin pumping cases, they start with standard cabbage valve cases, proceed to robotic cases, PTEs, major aortic cases, down to adult congenital cases, heart transplants and VADs. Towards the end, we introduce lung transplants after they're introduced to the convertible circuit, and then move on to standby and ECMO cases that can get a little messy. Finally, our ancillary cases such as HIPEX and angiovac are introduced. The new hire begins with one-to-one preceptor, and as comfort increases, the preceptor will back off, only being present in the room at critical time points. Eventually, the new hire will pump cases, but have an identified preceptor as a resource should they need any additional support or have any questions. And finally, they'll pump their cases as the rest of our adult perfusion staff do with an N+1 backer model. When the new graduate perfusionist passes their boards, there's palpable relief and celebration. But learning never ends for any of us. So onboarding really is career-long at a place like Duke, and overall in the profession of perfusion. To stay on top of our skills, we have a robust continuing education and competency program. Our program outlines annual requirements for our team, encompassing all the devices we use, the resources available, and what specifically needs to be completed at what time points. To facilitate ongoing clinical education of our team and to develop area experts, each member of the team is asked to become a super user by their 1-year anniversary in a couple of our devices, techniques, or special procedures. Super users undergo additional training and facilitate the in-services and competencies for the team. So everyone is pitching in and giving back. Also, by the 1-year anniversary, each employee is required to work towards becoming a clinical instructor and preceptor. This is something we take very seriously at Duke as a clinical affiliate for 4 perfusion schools. Our clinical instructor training process includes starting with observing a current clinical instructor in action on a complex case. The clinical instructor in training will then act as a clinical instructor on 3 cases while being observed and critiqued by a current clinical instructor. Areas of focus for our clinical instructors in training include the ability to be an effective teacher, an exemplary clinician, a role model, and act as a coach and evaluator. All of our adult staff also rotate through being in charge after the 2-year mark. The daily charge perfusionist arrives to the OR by 6 a.m. to start the day. They check in with our OR charge nurse and our charge anesthesiologist. They're responsible for the day-to-day clinical operations and guaranteeing coverage of all cases. They carry our team's emergency pager, in which all of our emergency perfusion needs and case postings are routed. The charge perfusionist makes sure our resources are in line, triages the pages they receive in collaboration with the charge nurse and anesthesiologist, and they attend our daily scheduling meeting and sets up the next day for staffing assignments and resources. To maintain consistency and transparency for our whole team, we use Microsoft Teams so we can pull it up on our phone at any time to guide our day and virtually communicate and track assignments and staff release order. We also utilize Teams in this way to facilitate our daily safety huddles as part of our tiered huddle system. The charge perfusionist is vital in running these daily huddles each morning. It allows our team to receive vital communication and updates, as well as to bring forth concerns. The huddle system keeps the team engaged and informed and is a form of continuous onboarding for our ever-changing profession. Thank you.
Thank you so much. presentation today.
I appreciate
Bring this up. I'd like to introduce Greg Diede. He's an area clinical manager for specialty care covering 10 hospitals based in Phoenix, Arizona. They cover 13 surgeons, 11 staff perfusionists. He's mainly out of Phoenix at Banner University Medical Center for the past 6 years. Graduated from Midwestern in 2017. And a first year AMSEC member and part of the planning committee. I'd like to thank Greg.
Thanks, everyone. Glad we saved the worst for last. It's my first time here, and a lot of people have been telling me to picture you all naked, but if I see Donnie and Curdy, I might have to relieve myself here. So anyway, yes, I'm Greg Diede, clinical perfusionist and area clinical manager, covering multiple hospitals in the Valley. One hospital in particular likes to take on some interesting cases that sometimes lead to interesting occurrences, to say the least. And if the title doesn't scare you enough or give you nightmares tonight, I'll have pictures and videos later on that will bring a whole new meaning to Mr. Sandman. So for disclosures, I was not the perfusionist involved in this particular case in any capacity. I merely gained as much information as I could through interviews with the surgeon, anesthesiologist, perfusionist, and review of the patient's electronic medical record. This is a very rare and interesting case that I hope no one has to experience in their career again, and hopefully, or will definitely bring up some thought-provoking questions that your team may need to discuss if you should ever come across such a similar scenario. So starting with a little history on our patient, he's a 59-year-old Hispanic male, 170 centimeters, 73 kilos, and this is a perfusion conference, so we all want to know the height and the weight right away, especially if it's anything related to the aorta. He was urgently transferred into us for a type 2 thoracoabdominal aortic aneurysm. Patient had a history of a type 2 thoracoabdominal aortic aneurysm with previous endovascular repair in 2011, approximately 12 years prior to his current stay. Patient also had a St. Jude mechanical aortic valve replacement in 2007, approximately 4 years prior to the endovascular repair, and was Coumadin compliant. Some other comorbidities that you likely could have guessed were coronary artery disease with possible CABG at the time of the mechanical aortic valve. These AMR notes were not as thorough as I had hoped, go figure. And AKI and CKD with likely acute tubular necrosis, which led to needing hemodialysis during the hospital course. Kind of important to actually get some blood flow to those kidneys. Transaminitis, maybe some blood flow to the liver as well. Anemia, sixth sinus syndrome, pulmonary edema, and you guessed it, malignant and refractory hypertension that took Kosarek, clonidine, hydralazine, losartan, nifedipine, spironolactone, and IV nipride to control. The patient originally presented to a hospital in southern Arizona with chief complaint of bilateral scapular pain for the past 2 weeks. CT revealed type 2 thoracoabdominal aortic aneurysm, 8 to 10 centimeters, depending on who's measuring. The surgeon recalled 10 centimeters, but he also likes to fish in his spare time, so. And these jokes aren't getting any better, just so you know. But, with concern for endovascular stent graft leak in the superior anterior portion, it was then transferred to our facility for a higher level of care. Here's a CT scan that my surgeon so graciously recorded with his cell phone. So the actual reading was aortic aneurysm repair and endoluminal stent placement. There is severe prominence of the extraluminal aorta. There are some areas of associated internal high attenuation. A crescent-shaped focus of hypoattenuation is noted along the anterior upper stent graft. A component of endograft leak is included in the differential, including type 1 proximally. No evidence for dissection. And you can see how massive that thing is in there with the endograft stent. So, starting the hospital course here, the patient was transferred to us the next day from southern Arizona, but surgery was postponed until the patient could be optimized further. Then on day 5, since initial ED visit, the patient coded asystole, was in complete heart block, subsequently intubated with a temp pacer placed. Later that day, TEE was performed with report of external to endovascular stent. There is a large thrombus burden, starting proximal, descending aorta, and extending distally. Distal portion of the descending aorta was not well seen. There appears to be flow outside of the endovascular stent on colored Doppler interrogation. The next day, the patient had a dual chamber pacemaker implanted. The day after that, the patient was extubated without difficulty. On day 11, venous ultrasound noted non-exclusive thrombus of right internal jugular vein. Heparin drip was restarted. Apparently, heparin was DC'd previously and was told to resume, and iron R was no longer therapeutic. Then finally, in the morning of day 17, the patient was ready for surgery. But are they ever ready? Probably not. So now we get to the OR part finally. The patient was brought in, central lines and lumbar drain placed. The patient was placed in the right lateral decubitus position, left side up. The patient was cannulated with a 21 French arterial cannula in the left femoral artery, as well as a 25 French venous cannula that was inserted in the left femoral vein. Upon CT review and open visualization of the thoracic aorta, the surgeon team, CT and vascular surgeon, agreed there was enough real estate on the aorta distal to the left subclavian and proximal to the endograft that they could successfully place a cross clamp on the aorta without the need for deep hypothermic circulatory arrest. They decided to use a partial bypass technique where the heart-lung machine would perfuse the lower body and the heart would continue to pump oxygenated blood from the lungs to the upper body. This would require a balancing act from the perfusionist to make sure the heart had enough volume to perfuse the upper body while having enough volume left over in the reservoir to perfuse the lower body. We have used this technique in the past for these certain situations, although the majority of the time we elect to circ arrest, which was the one main regret from the surgeon on this particular case, and recommends to utilize circulatory arrest in these situations from here on out, and you'll see why in just a second. The patient was anemic upon arrival to the OR, which they always seem to be anemic at this fun and fabulous facility, so 2 packed cells were placed in the prime, along with the rest of our typical prime drugs, crystalloid, 1,200 cc's of plasmolite, 25 grams of mannitol, 50 milliequivalents of bicarb, and our moneymaker, 10,000 units of heparin. Here are a few intraoperative pictures to start building the tension a little. Starting to see this massive guy hiding under here. There's a good shot. And so the miracle of cardiopulmonary bypass was initiated. Then we were finally able to incise the massive aorta, which now leads us to the part where nightmares are made of. The aorta was open longitudinally, and you can begin to see what's lurking beneath. Sometimes you never know what you're going to get. It might be Holy shit. Yes. As stated in the surgeon's op notes, massive amounts of old granular liquid type of thrombus around the stent graft and in between that and in the aortic wall itself, in which he had never seen before. Just can't be good. So they continued with the procedure. They were able to remove the endovascular stent graft and began to sew a 24 millimeter Dacron graft to the proximal descending aorta. At this point, they started to clean out more of the leftover endovascular graft and the clot, but the patient had exceptionally large intercostal arteries that began to bleed progressively, which led and forced the surgeon to place pump suckers in the thoracic cavity, as you can see in this video, along with a dirty throwaway sucker, and you can see him continue to scoop out massive amounts of clot. Probably saw a little sump sucker flying there. It's the beginning of our issues here. And let's see, one last big scoop. Oh, yeah. Not long after, this obscene clot began to coat the reservoir of the heart-lung machine. As you can imagine, the filters began to plug up, and the reservoir began to pressurize. They got to a point where they no longer had venous return in order to flow after dropping 18 units of red blood cells, 1 liter of albumin, 4 liters of plasma over the course of the procedure, while the ACTs were super therapeutic the entire bypass run. Then the patient became hypotensive and cardiac massage was initiated. It was then decided to switch out the entire heart-lung machine with a freshly built and primed pump. Luckily, we had another perfusionist in-house at the time that was able to assist our primary provider in switching over the patient to a new pump. And these water lines just never seem to stay clean around here. Although a new pump wouldn't matter as it soon succumbed to the same fate as the original pump did, but it bought enough time for the distal portion of the aortic anastomosis to be completed. Unfortunately, the patient continued to hemorrhage even while care was taken to oversew the extremely large intercostals, but then began to ooze through all suture lines and needle holes. They were unable to keep up with the massive volume loss, and the patient went asystole. The patient was tightly packed, heparin was reversed, and CPV was converted to VA ECMO, but was still unable to flow despite massive transfusions, and the patient expired on the table. So after discussing this case with the surgeon, he reiterated to stick to what you know works best for these types of cases in terms of circ arresting versus partial bypass with a beating heart. He believes they could have had a much different outcome if the patient was cooled and they were able to clean out all the clot and debris while under circulatory arrest with the heart-lung machine turned off. Hindsight's always 20/20, but they believe they were doing the patient justice by electing not to circ arrest at the time. We perform this procedure approximately 10 to 12 times per year, typically with great outcomes. Our aortic surgeons are phenomenal, and to have someone expire in the operating room is a very rare occurrence, even with some of the sickest patients. But who would have guessed that they would have had this massive amount of clot and atypical thrombus hiding inside of the aorta? I also believe that performing such critical cases is best carried out at a busy facility that would typically have other providers from all specialties around that could help physically assist or give advice in crucial moments. We do not practice an N+1 model, although another perfusionist just happened to be finishing up with another case next door when they decided to switch out pumps. Inevitably, it did not change the outcome in this case, but could prove beneficial in future cases. Transitioning to the topic of the thrombus itself, the surgeon and I did discuss what he thought may have led to this type of thrombus formation, such as the fact that the patient had a bileaflet mechanical aortic valve placed in the aortic position, which leads to no blood path flow irregularities. There are areas of stasis, areas of recirculation and regurgitation that leads to high turbulence and shear stress that becomes more disrupted as the blood travels further downstream. Unfortunately, no histopathology was performed on the clot that was taken from the patient, but tests for bacterial and fungal infections were negative. Chronic Coumadin use was also hypothesized as a possible culprit to forming such unusual clot. Studies of Coumadin have shown hypercoagulability effects even within a target INR range of 2 to 4 in the presence of contact protein activation. Coumadin has been shown to have little influence on decreases in factor 12 mediated thrombin generation, which leads to weaker, more disorderly clot matrix that lyses more slowly than normal plasma from subsequent decreases in factor 13, the fibrin stabilizing factor. Coumadin has also a vasculopathy connection from the inactivation of certain vitamin K dependent proteins such as protein C and matrix gamma carboxyglutamic acid that has shown to result in arterial calcification. One study even went as far to say, in sum, the results of this investigation coupled with previous clinical and biochemical investigations support the concept that warfarin therapy cannot predictably provide safe anticoagulation in patients with devices and blood biomaterial interface. All of this paired with the EV stent graft as another foreign surface for the body to engage with created the perfect recipe for impeding disaster. So how can we prevent thrombus generation on foreign objects in the bloodstream without the increased risk for hemorrhage? My former professor, the esteemed Dr. Nieder here, will have my head for not using this cell-based model of coagulation here, but it was pronounced that knocking off the factors from the top of the contact pathway would better serve the need of reducing thrombus formation without the risk of hemorrhage. Targeting the inhibition of the intrinsic pathway would still allow for thrombus formation without the risk of hemorrhage. Targeting the inhibition of the intrinsic pathway would still allow for the proper function of the extrinsic pathway that is most responsible for the hemostatic plug. Although factor 12 inhibition did not show much promise in terms of significant decreases in thrombus formation, most of its positive attributes mainly came from the reduction of the kallikrein-kinin system for the hopeful treatment of hereditary angioedema. So next in line is the factor 11 inhibitor that is more likely to prevent pathological thrombus formation, considering thrombin's positive feedback loop, which promotes further activation of factor 11 with exponential increases in thrombin and fibrin generation. The study suggested a lower Coumadin dose and acceptance of lower RNR range in conjunction with a factor 11 inhibitor would be beneficial, would be beneficial at this point in the trials, although there is optimism that a factor 11 inhibitor would be sufficient enough in decreasing thrombus formation during exposure to foreign materials such as mechanical valves and extracorporeal devices. And here are a few hopeful drugs to look for in the future that are progressing to phase 3 clinical trials. As of April of 2023, antisense oligonucleotides, monoclonal antibodies, and small molecules, which is currently the only available oral drug out of these. So anyway, getting back to our original disaster case, hopefully if anyone comes across this particular scenario in the future, just elect to place the patient under deep hypothermic circulatory arrest to allow for further control of the unknown. Thanks.
Yes, hey, a couple quick questions. not in regard to what you were talking about. I apologize. I'm going to jump forward a little bit to Dr. Kosarek, if I pronounced that correctly. If I didn't, I apologize. Thank you for coming to give us a talk. The case you presented with the patient that had the flail posterior leaflet and the right heart failure. Could you share some of your thoughts on weaning strategies in that patient from cardiopulmonary bypass in terms of SVR and preload SVR from the standpoint of obviously coronary perfusion and higher perfusion for the right heart, and also your thoughts on Primacor from the standpoint of increasing cyclic AMP, not so much from prolonged or pulmonary hypertension, reversible pulmonary hypertension?
Yeah, thank you. That's a great question. First name's Logan, by the way. That's easy. Or just I respond to anesthesia as well at this point.
Yeah.
But yeah, really, any patient with right heart dysfunction can be a very challenging case to come off pump with. That case in particular, I can tell you, we used a mix of milrinone and nitric oxide was kind of the answer there. And so whatever inhaled vasodilator you have at your place, whether it's a prostacyclin analog, or I would think nitric oxide is probably the more popular one nowadays, or even milrinone, inhaled milrinone. We don't have the ability to do that personally, but I would love it if we did, in part because it works differently than the prostacyclins and the nitric oxide, and so you could use them both. You could use two pulmonary vasodilators. Some folks are able to do that. We are not, but you could. And so sometimes what we'll do, and I don't think we did it for this case, but even if you aren't able to, you don't have the equipment to be able to deliver inhaled milrinone, you could just take it, concentrated dose in a syringe and squirt it into the endotracheal tube. And we've done that a few times as sort of a bolus dose. But honestly, the limiting factor for milrinone for the most part is whether there's enough systemic pressure to be able to give the dose that you want. We often think of milrinone as sort of a right-sided drug, but it works on both ventricles just fine. So I feel like another scenario where it comes up as being very useful would be the LVAD that's hypertensive. That's like a perfect scenario in my mind that you could use milrinone, because they almost always need a bit of right heart support, and the vasodilatory effect that it will have on the systemics will help lower the blood pressure too, to increase forward flow. So yeah, the milrinone, great idea for either ventricle being dysfunctional, but in particular the right, and an inhaled agent, I would say, or both come to mind. I mean, you're right about maintaining adequate perfusion to the right side. The advantage the right side has usually in terms of coronary perfusion is that it's perfused through the whole cardiac cycle rather than just in diastole, because the aortic pressure is hopefully always higher than the right side. That's not always the case, but in most cases it is. But yeah, those are the things that come to mind.
Thank you. My next question is for Greg. I apologize, I forgot your last name. That's a great case. Years ago, I worked at a great institution where we did a lot of complex aortic cases, and we did very similar for type 2 and 3 dissections, fem, assuming they didn't have any major coronary disease. Let the heart provide preload for the upper top of the part of the body, and we perfuse the bottom. Interesting about that case was the patient was in the hospital for quite some time. I think you said 11 days before it was time to operate, given the system of events. My thought process on that is, you might have presented it, I could have missed it, was when you gave the systemic heparin dose for bypass, was there any indication for any type of AT3 deficiency? Where I was going with that is, you know, I've seen standard dosing protocols for, I'm under the assumption that when you begin somebody on Coumadin, obviously they need to be started on heparin, because Coumadin can inhibit protein CNS, making you hypercoagulable. So if you have a patient that's been laying in the hospital for several days on heparin, and then you make the decision to start Coumadin, you know, the standard bolus of heparin that you would give with that Coumadin may not be enough to cover what the inhibition of protein CNS could cause on the coagulation side due to AT3 deficiency. So it was just a thought I had. Didn't know if you had any data on that from that case study.
Yeah, no, as far as I know, they said they didn't have any issues with anticoagulation at the beginning of the bypass and through the entire run of it, but that's a good thought process, but I think it was fine in the beginning,
Okay, thank
as
you.
far as I know. Thank you.
Can I ask a question, Greg? Why, I mean, that stuff coming out of the aorta was fascinating, and you said they just did a culture and sensitivity. Why didn't they send it off and look at it under the microscope? Because I'm thinking, well, you know, there could be parasitic diseases, fungal diseases, other stuff. Like, didn't you just think, it might be interesting to see what this looks like?
Yeah, I wish they would have, but that didn't happen. I'm sorry. So we may never know. Now you really won't be able to sleep at night.
So we're reaching the end. I do have I have a question for Desiree. First of all, I just want to thank her personally. Desiree's not feeling well, and she's a trooper, so she made a point of sticking around and being able to do this talk for us. So we're very grateful to you for doing that, and I appreciate it. And you had a lot of information, and again, you breezed through it for us for our sake, and I appreciate that as well, to stay on schedule. It's very regimented, your onboarding process. How often are you able to stay on that target with those weeks, as opposed to if you have maybe a new grad who probably needs a little more support?
Yeah, occasionally we do have to extend certain portions of the training or play catch up in different areas, because you do need to personalize it depending on the hire. And some of it is the ambition of the new hire too, because, you know, they have to seek out some of these opportunities and, you know, get some of these cases done too. So it always works out that by the time that they're taking their boards and pass, that they're done.
You're ready. Thank you so much.
You're welcome.
All right, we want to thank our guests today for the talks you gave, the really wonderful topics. And if you have any other questions that didn't get answered, please feel free to come up and speak to them. We'll end this session now, and the next one starts at 5 minutes ago. So take a quick break and come on back quickly. Thank you.
Thanks, guys.
Yes, sir. Thank you.
I was like, remember all this stuff about